This presentation is adapted from Pulmonary, Sleep, Cardiology, and Critical Care Academy, an online CME-accredited course for advanced practitioners and physicians. I'd like to make sure we're all on the same page as we discussed the systemic circulation served by the left ventricle and pulmonary circulation served by the right ventricle. Blood flows through the body in a figure 8 circulatory pattern, passing through the heart twice with one full circulatory cycle. Let me walk you through one circulatory cycle, starting with the venous blood, which is deoxygenated blood, shown here in blue, returning to the right side of the heart via the superior and inferior vena cavas. I will indicate direction of blood flow with green arrows. Next, the blood enters the right heart and makes its way through the right atrium and right ventricle, which pumps blood to the lungs, through the pulmonary arteries, which repetitively branch down to the microscopic capillary network, where the blood picks up oxygen from the alveoli in the lungs and leaves the lungs in the pulmonary veins and oxygenated blood, with oxygenated blood shown here in red. Note that the pulmonary arteries are the only arteries in the human body that contain venous blood, and that the pulmonary veins are the only veins in the body that contain arterial blood. That's because the lung is the only organ in the human body that adds more oxygen than it removes, given its primary function to support human gas exchange. Next, the arterial blood returns to the heart through the pulmonary veins entering the left atrium and then moves through the mitral valve into the ventricle, where it is then ejected during left ventricular systole, through the aortic valve into the aortic root to enter systemic circulation and travel with oxygenated blood towards vital organs where oxygen is consumed. This completes the figure 8 once blood travels around the body, returning on the venous side back to where we started. Now, let's turn our attention to the normal cardiac anatomy, starting with the aorta, the main artery leaving the heart to supply blood to the entire human body. After the aortic arch, the aorta continues as the descending aorta towards the lower extremities. The main pulmonary arteries, which send blood to the right and left lungs via the right and left pulmonary arteries, is shown here. After blood picks up oxygen from the lungs, it returns back to the left atrium via 4 pulmonary veins. The superior and inferior right pulmonary veins return blood from the right lung, and the superior and left pulmonary veins return blood from the left lung. Finally, venous blood returns back to the right heart from the systemic circulation via the superior vena cava and inferior vena cava from below. Now let's review the 4 main cardiac chambers. The heart is essentially 2 hearts working as one. The right heart receives deoxygenated venous blood from the systemic circulation into the right atrium. Then the blood is pumped by the right ventricle to the lungs via the pulmonary arteries. Likewise, the left heart receives oxygenated blood from the lungs into the left atrium. Then the blood is pumped by the left ventricle to the systemic circulation via the aorta and its branches. Finally, let's review the anatomic position of the 4 cardiac valves. The principal function of cardiac valves is to ensure blood moves forward. An inadequate opening of these valves is termed stenosis, where an incomplete closure leads to valvular insufficiency due to regurgitation of blood flow in the wrong direction. On the right side of the heart is the tricuspid valve, which lies between the right atrium and right ventricle. This valve is open during diastole to allow blood to flow into the right ventricle from the right atrium, then closes during right ventricular systole to assure no backflow during right ventricular contraction. The pulmonic valve lies in the right ventricle outflow tract to assure blood flows in one direction out of the right ventricle into the pulmonary artery on the way to the lungs. This valve normally opens during right ventricular systole and closes during diastole. The aortic valve lies in the left ventricle outflow tract to assure blood flows in one direction out of the left ventricle into the aorta on the way to systemic circulation. This valve normally opens during ventricular systole and closes during diastole. The mitral valve lies between the left atrium and left ventricle. This valve is open during diastole to allow blood to flow into the left ventricle from the left atrium, and then closes during left ventricular systole to assure no backflow during ventricular contraction. Now let's take a close look at the layers of the heart wall and pericardium. Let's zoom in on a representative section of the ventricular wall. The myocardium is the main muscular layer of the left ventricle. In healthy individuals, myocardial wall thickness can be up to 15 millimeters, although the wall thickness varies within the heart. For example, the wall thickness tends to be the thinnest at the apex of the heart. The endocardium is the innermost layer of the heart, lining the chambers and extending over the four cardiac valves, chordae tendineae, and papillary muscles. The endocardium is comprised of three distinct layers. The innermost layer, the endothelium, is a single layer of flat endothelial cells in direct contact with the blood-filled chambers, allowing a smooth surface for blood to flow across. The middle elastic layer is comprised of a mixture of smooth muscles and collagen. The subendocardial layer contains loose elastic tissue, collagen bundles, nerves, and small blood vessels. The endocardium also contains Purkinje fibers, which stimulate the myocardium to contract. The visceral layer of the epicardium, the outermost protective layer of the heart, is composed of mesothelial and connective tissue. The parietal layer of the epicardium is the outermost layer of the epicardium and has an epithelial layer, shown here in pink, abutting the pericardial space, and an outermost strong fibrous layer on the surface that helps anchor the heart in place. The visceral and parietal layers is separated by the pericardial cavity. This space usually contains between 15 and 50 milliliters of pericardial fluid. In pathologic states involving either in elevated hydrostatic pressure, such as seen in heart failure, or increased permeability, such as seen in inflammatory, infectious, or malignant processes, a large amount of fluid can accumulate, causing significant pericardial effusions. Pericardial effusions may be asymptomatic, quite symptomatic, or lead to severe hemodynamic compromise as the pressure in the pericardial space rises through a process known as cardiac tamponade. We will discuss the physiology of tamponade during our review of hemodynamics. It's important to recognize that the pericardium reflects one surface to create the two surfaces I just described. In other words, the visceral and parietal layers are really just one surface that turns around at the top and bottom of the mediastinum. Let's look at some more structures and vessels that can be seen on the anterior surface of the heart. The auricle of the left atrium, also known as the left atrial appendage, is a small, pouch-like structure on the top of the heart that extends from the side of the left atrium. It's shaped like a windsock and is derived from the left wall of the primary atrium during embryonic development. The left atrial appendage can act as a decompression chamber when atrial pressure is high. Pooling of blood in the LAA can lead to a clot, which may enter the circulation systemically, leading to strokes and other systemic embolic phenomena. The left main coronary artery comes directly off the aorta, just below the left atrial appendage, then immediately branches into the circumflex artery, which runs laterally in the anterior groove, and the left anterior descending artery, which runs anteriorly in the intraventricular groove. On the right side of the heart, The right coronary artery comes off the right lateral wall of the aorta and runs laterally in the interatrial groove. Let's turn our attention to the posterior view of the heart to see cardiac structures from behind. The posterior interventricular artery, also known as the PDA or posterior descending artery, is the only one of the four major coronary arteries that does not arise from the aortic root or the LMCA. In about 70% of patients, this artery arises as a branch of the RCA. These patients are termed right dominant. 10% of the patients have their PDAs rising off the circumflex artery and are called left dominant. The remaining 20% are supplied by branches off of both the right and left coronary arteries and are called co-dominant. In spite the name posterior descending artery, this artery is more inferior than posterior. The coronary sinus drains over half of the venous runoff from the heart into the right atrium. As I mentioned before, the pulmonary arteries are the only arteries in the human body that carry deoxygenated venous blood as the right ventricle pumps venous blood that has returned from the superior and inferior vena cava to the lungs to oxygenate. Likewise, the four pulmonary veins comprise the only venous system in the body that carries oxygenated blood back to the left atrium, which is relatively posterior structure adjacent to the esophagus. Blood flow from the pulmonary veins is maintained by a pressure gradient between the pulmonary capillary bed and the left atrium. This pressure gradient is actually generated by the RV. About 2/3 of the pressure gradient is dissipated in the precapillary arteries and arterioles, and the remaining third of the pressure gradient is dissipated in the postcapillary veins and venules between the pulmonary capillary bed and the left atrium. I would like to briefly review the main branches of the three principal coronary arteries. First, starting with the LAD or left anterior descending, which as you may recall is a branch off the short left main coronary artery that runs down the anterior surface of the heart in the interventricular group as shown here. This artery gives off large diagonal branches typically numbered sequentially D1, D2, which are diagonal 1 and diagonal 2. Several septal perforated branches serve as a blood supply to the anterior ventricular septum. Finally, in about 15 to 30% of patients, the distal main coronary artery trifurcates into a third branch. It would be difficult to call this a branch off of either the LAD or the circumflex because it comes off at a point where the left main bifurcates into the LAD in the circumstance, effectively trifurcating off of the left main. So this is simply called the ramus. The left circumflex artery is the second of the two main branches off the left main coronary artery. This artery runs down the intraatrial groove laterally and wraps posteriorly as shown here. The circumflex artery gives off marginal branches as shown here. These can be labeled M1 and M2. If you'd like to learn more, please visit our educational center at pulmonaryandsleepacademy.com, where we have 70 hours of self-paced online CME-accredited courses covering pulmonary, sleep, cardiology, and critical care medicine. Please enjoy more of our short visits on our PSA YouTube channel. You can purchase our full courses with an exclusive 10% discount code using YouTube10.